All right, for everyone joining, we're just going to give it a quick second to let people come in, and then we can get started. So sit tight for just another minute or two. Okay, people will continue to come in, but I do want to be respectful of everyone's time. So I will go ahead and get us kicked off. So just a little housekeeping. If you have questions for Warren as his presentation goes on, please drop those in the Q&A. That should be a button on your screen, and we'll make sure those get answered for you. And just to give you a little bit of background on Shadow, we work closely with Schneider Electric. We are a VC firm focused on the built industry, so we work with a lot of architects, engineers, contractors within this space, and within our technologies, our startups that are in this space. So that's a little bit of background on us. And we are joined today by Warren Rosebraugh. He's the Director of Solution Architects at Schneider Electric. So Warren, I will go ahead and pass it over to you.
All right, thank you very much. Yes, my name is Warren Rosebraugh, and as the Director of Solution Architects for Schneider Electric, I have been with the company for 25 years. Or going on 25 years. In the last 8 years, I've focused on really looking at healthcare as a complete segment. So my background, a little history, I am a computer science major, so a little different than architect or electrical or mechanical type of engineer. I have done a lot of projects and been doing smart buildings since 1996, roughly. I ran our Asian operations for many years where smart buildings were happening back in the late 90s. So today we're going to focus in on healthcare, and I'm going to try to change it up a little bit, especially since it's kind of a unique crowd that we have today. So you'll see that I'm coming live actually from Philadelphia. This is our what we call a low voltage integration lab here on the PenMed project. So my team has been involved with PenMed, working on an IPD and integrated project delivery, building the smart hospital. So we'll go through it. We'll talk about technology. We'll talk about the opportunities that are here, and we'll go through what a smart hospital looks like. So I do want to put a shout out. So we are sponsored by our engineering consultant group, and if you want to download this presentation, you can go to our PROficient site for the engineering community, and you can see where you register today at schneider-electric.us/E2E. So this is where this presentation, the drawings, and given the time that we have today, I will not get through all of this in detail. It's usually about a 90-minute session, so you might want to look at some of the drawings that are on this site. So what are we here really talking about today? We call it a solution-based design process. Interesting enough, it was created by NASA, and it's a way of thinking out of the box and looking at things differently. So we talked about startup companies. I think it's a prime example. This process may be a little longer than agile and kind of startup type companies are using today. But the real methodology or the reason for doing this, you know, Schneider Electric, like many other companies that are out there today in the industry, have acquired and bought a lot of different companies and combined them together. So we're looking at roughly over 150 companies that we've acquired. And if you look, there's about 35 of those companies that play pretty big in healthcare. So if you look at these are products that are used in the market. And as I said, a lot of the industry is heading this way. What was unique about Schneider and what we wanted to try to do is many of these products are simply commodities and they're purchased through the contracting channel. There's different RFPs that go out and they're looked at as siloed systems. So we really wanted to focus in on how do you bring these different brands and products together for an overall solution for healthcare, and really, really add value. So to do that, we had to find a methodology to use, and this was the solution architect methodology. I'll apologize to the architects out there. I respect what you do, so I'm not trying to take your title, but it is a term used in the industry a lot on the software side. And the process that we learned was really about looking at identifying all the different stakeholders that are in healthcare. So if I go back over my 25 years, my first integrated smart hospital was in 1994 at Presbyterian Hospital in Dallas, and had worked on that. And to be honest, my stakeholder back then was a facility director and the team that ran the central boiler plant. And maybe later on, it was a security director if you were doing card access. And if you step back 10 years now, maybe an energy manager because these large healthcare systems were trying to save energy. Well, I have to be honest, today I sit in the middle of PenMed's IT organization, and that's because we're working on their product or project and we're co-developing with their IT organization. So the stakeholders that I work with today are more CIOs, CTOs, chief nurse officers, chief financial officers, chief infection control, and a lot of clinicals, so doctors, nurses. And in this lab, we spend a lot of time working with those stakeholders to really understand what their needs are. So number one, identifying who the stakeholders are. Number two, identifying those needs that are unique to each stakeholder. Also, it's important to understand the different functional areas because in healthcare, there's a lot of regulatory compliance and a lot of different regulations that really drive what is possible in different areas of a hospital. And then, and probably most important, is how are people going to use technology? And when I say that, it's actually building out patient room mock-ups. It's bringing patient advocates. It's bringing nurses from different departments in and really using the equipment that you see behind me on the wall and understanding, what data, is it HIPAA compliant? How are they going to use it? Can we really help with some of those core needs that they have on a day-to-day basis? And once you've done that process, then and only then do you really apply those brands that I was talking about, software, the hardware, that building management system, that low voltage power system that goes in, or medium voltage. So for us, this was really a big change in how we thought and the methodology which we approach. So I highly recommend it, for any company starting out today or trying to think out of the box and how do you do something different. I'm roughly 59 years old. I've been in the industry a long time, and you have a way of getting set in how you do things. So this was really thinking out of the box and trying to look at things differently. And instead of in the past, we would always start down here in the bottom, and we would come in and tell you how great our brands and products are, how people are going to use them in different areas to meet their needs. So a big shift. Really understanding healthcare as a segment, understanding the stakeholders and their needs, and then focusing in directly. So that's what our presentation is going to be about today. It's not being scared to take a risk and go out and look at things differently. So what are the 5 core needs? Well, the 5 core needs that over the last 8 years, looking at healthcare specifically, that we really focus on are increased patient satisfaction and outcome. So it's understanding the Affordable Care Act, pass the HCAP survey. Those are surveys that the patient takes, and it directly impacts patient satisfaction, directly impacts reimbursement from the federal government. How do I help with clinical outcomes? How can technology be used to reduce hospital-acquired infections? How can the technology be used to reduce falls? So, in the past, I would have had a conversation about temperature and humidity. Today, you're having a conversation with the CFO about how technology can reduce falls and how we can prove that so we can actually impact the liability premium that the healthcare system is paying for their insurance. How do we improve financial performance? Hospitals run at a very low EBITDA, and if you look at some of their expenses, how can we directly impact that? improve safety and security of the patient and the staff. So we talked about reducing falls. A lot of people don't realize, if you don't truly understand the stakeholders' needs, you don't realize that if a person in a hospital bed gets up to go to the restroom at night and slips and falls down, and let's say they break their hip, which, bless her heart, my mother has in the past in a nursing home, that healthcare system is responsible for her getting well and has to pay those fees. So how can technology help reduce that? How do we simplify regulatory compliance? If you think about the job, the stakeholder of a facility director or facility manager, once every 3 years, the Joint Commission shows up and does an inspection. And if you don't have your documentation, if you haven't done your testing, if you don't have things right in your healthcare system, you can be fined or shut down. So it's an extremely stressful job. And how do I improve staff productivity? How do you do more with less? How can technology help you do more with less people? So all key factors in really understanding this. So interesting enough, I talked about doing a lot of patient room mock-ups. I think anyone in the healthcare industry has been involved with this. Usually it's about how the clinicians flow, how they get their supplies, how many steps are you taking because a nurse is on their feet all day long. How many steps does it take to accomplish what you need when that nurse's call bell is pressed? Well, that's where we started. So you see a lot of the needs like patient satisfaction, energy efficiency, quietness, how loud, how noisy is a patient room. Well, we've come a long ways because today, what you see behind me is really putting a virtual video wall at the foot of every patient's bed and really bringing information to them. So you'll see information coming directly from their EMR, electronic medical records, on the right-hand side. You see entertainment as far as television, weather, actually controlling the room. So empowering the patient, just like the surveys we take with all our employees. If you can empower the patient, that survey they take, is you're going to get a better response and you're going to get a better answer. So technology has come a long ways in really being able to integrate. Now, with technology comes cybersecurity concerns. So we'll talk a lot today about those issues as well. So during the process, this is not the only project my team has been working on with Schneider Electric. We have several other customers throughout the country, and we've learned a lot of lessons learned. I think you talk about startup companies. Every startup fails a few times before they really get successful, or the people that have the nerve to do those startup companies. Typically, there's a couple failures before you're successful. Well, same principle here. We've learned a lot over the last 8 years in focusing directly on this segment. We call them life cycle considerations. So let's talk about the first one here. So anyone in the industry knows that a typical construction process, what happens is you design technology into the RFPs, it gets bid, and then you're short on your CapEx budget, so it gets value engineered out. So what we're really trying to do here is, how do you look at technology? How do you make sure that the customer gets what they want in the end? And what this chart is showing you, it's really about level setting the stakeholders that are part of that design team making decisions. So it's important that they understand that, hey, over the next 3 to 5 years, 25% of your spend is going to be that CapEx budget to build the new hospital. 75% is operating expense and the energy cost to run that building over the next 25 to 30 years. So why is that important? Well, literally, I've sat in design meetings talking about technology, talking about how it would save substantial energy for a hospital, which puts income directly to the bottom line. And I've had a CTO look at me and say, why would I spend that extra money? We have a CapEx budget that we have to hit. Why would I spend that extra money when I know we're going to replace that technology in 3 to 5 years? I mean, let's be honest, this hospital is not even opening for 3 years, and we're going to be replacing it almost immediately. Different stakeholders have different points of view. So if you're in the IT world, you're used to replacing, like my PC, every 3 years. Cisco switches or switches that you put in your TDR rooms, same process. If you're on the clinical side and you're part of this design team, how often do you replace portable medical devices? You know, those ventilators we hear so much about have probably a 5-year life expectancy. So it was important to let people to know that your meters, your transformers that are your power transformers from Square D, that building management system, they're going to be there for 15, 20, 25 years life expectancy. So spending an extra dollar today can pay back over the next 25 years 1,000 times over. Another thing that's very important to understand is if you're an ASHE member, you know ASHE has a program called Energy to Care. And Energy to Care is about cutting energy across all healthcare by 20%. So if you have a chief financial officer in your design meeting, maybe they come in once a month and they're looking to see how the budgets are going, show them this slide. 72% of the energy, this is published by ASHRAE, 72% of the energy spent in a hospital is around mechanical systems. If you look at it, 15.3 is to cool the air, to take out humidity, 37.7 for reheat, to do those 7 air exchanges that are required in a patient room per code, per ASHRAE 170. Or the 25 air exchanges that are needed in an OR. And that's about reducing infection control, and it's quite interesting. So if you think about that, the light bulb went off for me and made me realize there's a lot of opportunity here. Interesting enough, I was in a global healthcare meeting this morning from Schneider Electric, and we had a gentleman from the healthcare industry that runs some major hospitals in Pakistan. And it was quite interesting. They were all excited about just actually having positive or negative pressure in a room and you know, not just opening the window. So in the US, we're past that point. Now we can really look at, you know, technology and how we can apply. The other thing that I would say is extremely important is understanding IoT, Internet of Things. I have a lot of customers now that in the IS world working with these large healthcare systems, they started to call it the IOFT, Internet of Facility Things. And if you understand their concerns, then you start realizing it's about cybersecurity. It's about how do you put these devices on the network and how do they get authenticated. It is about how it's set up with the virtual environment. So it's extremely important to understand the world of IoT. And also today I have one project that I'm working on. We're putting 24 Cat6a drops in every patient room, pushing 100 watts of power into those rooms. So if you think about that in a design sense, if you're an MEP firm, on the electrical side, we just moved all the distribution out of the TDR rooms, not the electrical closet. We also just pushed a BTU load into those closets because of the power supplies that you have to be able to push that. But many of the devices you see behind me on the wall, they're PoE powered. So distribution in the patient room is changing greatly with the concept of UPoE. Lastly, I would say it's extremely important to always talk about energy management life cycle. You saw the opportunity to save energy in healthcare, but it's also important to understand how you're using it. So if you take, for example, what's going on in California, we have a large customer out there where literally they're killing power to a live hospital on windy days. We all hear about this on the news. In the same sense, they're running on their generators, that's great, but they're also getting hit by the EPA for their carbon footprint. So understanding your whole energy strategy, designing an energy efficient hospital is extremely important. So I always like to ask myself these 5 questions. You know, what is my strategy on energy? How am I buying and procuring? What is my overall healthcare, you know, my overall spend for energy across my healthcare system so I can get good rights or good pricing for my contract? How do I control? How do I optimize? If I told you how many customers I have that spend the money to get LEED certified the day they open, and 2 years later they feel like they should give back the award because basically they're running their system in manual process just to keep different people satisfied. So it's very important to optimize and keep it at that same design level, which is the last question on how am I performing. All right. So as part of that, what are we here to talk about today? We call it an intelligent infrastructure, which is based on mechanical, electrical, security. Security is card access, video, and real-time location systems. And ICT, information, communication, and technology. Basically not your data centers, but more around your TDR, your technology distribution rooms. So how do I take that? How do we work in the different functional areas? So understanding the regulatory code in each of these areas is extremely important, whether it's from an architect's perspective on the space required around a PC and the different areas within the layout, physical layout, whether it's an MEP and how they're designing their air exchanges, all extremely important. The next thing we like to look at is tying it back to that energy management life cycle. So interesting enough, if you think about the example I mentioned in California, if I would have gone back 5 years in time and said, could you put solar and wind distributed energy sources, could you actually run those on your critical loads within a hospital? I would have told you it's not possible. But we've actually, over the last couple of years, when you look at one of those acquisitions we had, ASCO and the ATSs, and our ability to drive our energy command centers, you can now drop out solar, drop out wind, and be able to transfer onto the generators without interrupting the waveform. So we've come a long ways. And once again, why have that discussion if you can't tie it back to one of those 5 core needs? So if you can't sit down, if you're trying to do a startup and you're looking at a new company, if you can't sit down and list out your stakeholders, list out your needs, and come up with that top 5 to 7, you know, how do I help with patient satisfaction? How do I reduce, you know, regulatory compliance? How do I help in that area? Those are all the key items. So an intelligent control platform is really what we're here to talk about. It's that IoT, it's bringing technology into the hospital. And there's roughly 28 low voltage systems that go into a hospital. Every one of these systems is bought in silos. There's a different company that comes and installs it. They may be a smarts and parts vendor, and they hire a subcontractor to pull the electrical wire. None of these systems share data. So, you know, doing any type of analytics is impossible. Trying to put gateways in to connect all these different systems and pull data and push it into the cloud is impossible. So how can we really look at data? How can we really look at the different concepts here? So what we want to do and what we have focused on, we started building our next generation of product about 10 or 11 years ago. And 8.5 years ago is when we really started focusing in on healthcare and to understand what is possible. So if you look at it, what we call an integrated control platform, and from a Schneider perspective, we call it EcoStruxure. That's our branded name for the products, and this is where our investment in product is gone. And the reason you do that is really, if you look at this, what we've realized to be successful in selling technology, we have to understand how this is contracted. We have to understand the different channels that it goes through, the different time frame that over a 4-year period, these things are bought. They're bought at different times, and a lot of times we're asking questions at completely the wrong time. So if you look at the color coding here, this is a little bit about how we figured this out over the last few years, and honestly have been very successful. Yes, we have great brands and products, but we've also been successful in telling how you contract this and how the technology can really help. So if you look at what we call the 5 core systems, it's building management, it's power management, which is power quality, it's energy management, which is your sustainability and your lead points, it's emergency power and testing, so your generators, your automatic transfer switches, your UPSs, flywheels, integrating all of that in with distributed energy like we talked about. I mean, it's low-hanging fruit when you think about all of the capability that already exists in a hospital to meet the Joint Commission requirements, and testing those generators, it makes bringing in distributed energy a simple low-hanging fruit. And then lastly, access control. So how do you bring in card access and how do you help? So the concept here is, you've heard single pane of glass for years, you've heard the ability, but really the problem and why it typically gets value engineered out is because you put these systems in place and they work in silos. They don't share data. They don't integrate with each other. And it's really, you know, sad. You used to have to program points in one system, program in another, and then develop some type of driver between the two. And even with open protocols like BACnet and Modbus and LonWorks, you still have that similar problem. But today with web services, what you can really do is now discover these different systems and really get the efficiencies that allow you to share this data. And that's what we're going to focus on for the next 15 or 20 minutes. Besides those 5 core systems and that single pane of glass, there's also the systems you see in blue. Those are systems that we've integrated to. We have our labs, like I'm sitting in today, our labs at our corporate headquarters, and that's where we really build alliances, and it allows us to integrate and develop what we call use cases to bring that added value. So real-time location systems, those GPS tags that allow you to track a portable medical device so you can find it on a large campus when you want to do maintenance. It allows you to do wayfinding. It allows you to basically see a patient who's trying to leave the building or elope. It also allows you to track staff and get workflow efficiency. So a prime example is a nurse wearing a badge. So when they walk into the patient room, when a call bell is pressed, it turns that call bell off automatically. It helps with their reporting because now their call bell time is much shorter. It helps the staff because they don't have to walk up to a system. It helps with infection control because they're not touching things. So use cases can bring a lot of added value. Integration with voice over IP. So taking your infrastructure systems and talking to the phone that a nurse may be carrying. And we'll talk about how that can really be beneficial. Visitor management, lighting control. Not just about turning lights on and off in a patient room, not about shade control, not just about empowering the patient, but now it's about white light tuning, using light color to maintain the circadian rhythm of the patient and helping them sleep more at night, which then helps them heal, which then means they're out of the hospital earlier. And if you understand the Affordable Care Act and how payment processing is done now, the healthcare system actually made the same amount of money if the patient was there for 3 days versus the 3.5. So now they have another patient in and they're generating revenue. So it really helps with increasing financially the bottom line. The other thing with lighting control, I would just mention, there's a lot of studies now about nurses working the night shift and their circadian rhythm getting a little bit interrupted because you're dimming the lights to allow the patients to sleep. And at midnight is really noon for the nurse. So you're messing with their circadian rhythm and they have an increased chance of breast cancer. So those are all items, finding those unique needs that we talked about, tying them back to technology. And just like you have evidence-based medicine, everything we're doing in this lab is evidence-based integration. If it doesn't bring value to the customer, why do it? If I can't directly reference it to one of those 5 core needs that we developed, it doesn't make sense to do. And that is really the key purpose. The systems you see in red, these are systems that are going to get chosen by the general contractor. You may stick with the fire system because you have it on the rest of the campus and you have a good service provider. Elevators are something that's really going to be a decision made on the construction side. Your emission discharge and transfer, your EMR system, is directly tied to your clinical teams. You're not going to walk into a CIO or CTO and tell them to change from Epic to Cerner, but there is an open protocol called HL7 that we can communicate and talk with. Also, if you look at regulatory compliance in a healthcare, computerized maintenance management systems, creation of work tickets, tracking your maintenance that is done, tracking that you're responding to alarms, all part of the reporting process. So integrating in and automatically helping to create work requests or work tickets, very critical. And lastly, nurse call and code blue. If you see the footwall behind me, when a code blue happens in a patient room, we're going to change things on this. We're going to put different information like telemetry information. We may connect in and show a remote doctor's face on the window. There's a lot of things are on the glass for the monitor. So understanding the different codes that are happening in a nurse call, being able to respond by changing lights, by changing the warmth of the light, doing different things within the room, all very, very critical. I don't know, is there any questions out there at this point that anyone has seen? I can stop and take a breath here. Short time, so I talk fast. I apologize. All right, I'll keep going until we get to the end here. It's important to put it on the overall network. So today, working with the IS or IT organization, understanding cybersecurity, understanding authentication of devices on the network, all very, very critical. If you work with the IT groups, you know they're concerned about the Internet of Things, these sensors, these devices that we put on their network. It's not what they're used to seeing. They're used to having a Windows PC. They're used to being able to look at servers. They talk SNMP, Simple Network Management Protocol. So how do we drive that same type of conversation with these devices when many of these devices you may only pay $100, $200 for? All right, so why do you put it on the network? Well, one of the biggest opportunities today in our industry is to really capture that data that I was talking about that's now shared between those core systems, pushing it into the cloud and developing the analytics. So I'm old enough that I've lived and been in this industry, the IT industry, for 30 plus years now, and understand that the word analytics or big data, it's probably overused, but the reality is we're at the right time and the right place to do this. So you start to look at proactive fault detection, being able to take that data and reach out to a younger person who hasn't been working in a central plant for the last 30 years, that doesn't have the experience and the knowledge, and be able to build that knowledge of these experienced people into analytics so they get a report in the morning that tells them, here's your top 10 issues you have on your mechanical system. And it's telling you that by energy consumption, so which ones are costing you the most money if you don't fix them, as well as patient comfort or the comfort of people in your building. Carbon footprint. We all talk about being green, talk about sustainability reporting, but do we really have the systems to combine the data to do proper carbon footprint analysis? Predictive modeling. So one of the most important things I've seen in the industry that I'm quite proud to be part of is by breaking down these silos, you can bring data together from separate systems and really start to predict. So a perfect example is looking at a central plant. We have a large healthcare system that we work with where we calculate a key performance indicator for the central plants. And that is done by looking at mechanical equipment that's running, being controlled by your BMS, combining it with meters from your power quality system and your energy usage, so you can look at this equipment's running at this efficiency, and then combining that with data related to weather, dry bulb, temperature, humidity, and being able to say, instead of showing all these great energy dashboards where you're showing, month over month or year over year, and it's a very reactive type of dashboard because you're looking at data for this month versus last year. Why not change it up if you can model on a given day at 75 degrees, 50% humidity, here's what plus or minus 2 to 3%, here's what your energy spend has been the last 3 years. So now you start to get dashboards that are proactive versus reactive. All right. Besides that, how do I do, how do I procure energy? If I don't know what my total spend is, I really can't focus in on getting energy at a good price. Standardized compliance reporting. It's about analysis around your generator testing. And a lot of what's going on in the industry today is the fact that a healthcare system is only as good as the last hospital they just acquired. A lot of healthcare systems are out buying hospitals that have gone bankrupt or gone out of business. I doubt very highly their maintenance was done very well. So bringing that hospital up to the same standard as your best hospital is really a key focus about reputation. Incident forensics. Today, we have analytics around our Square D power equipment. I can start to look at an oil-filled transformer. I can start to tell you, basically look at real-time oil samples that give you temperature, humidity, and gases that are released in the oil if you have an arc flash or potentially an arc flash in that transformer. So it's really about capturing the data, having the network in place and the type of technology. Number one, enough processor power to do this, which is where the industry has really gone over the last few years. So those PLC controllers are a lot faster. They have enough memory for cybersecurity. They have enough memory to really have IP stacks, Ethernet type IP stacks built into them. So they're IP-based controllers. And to be honest, our customers are now ready. So I look back at that first hospital I did in 1994 and tried to integrate a lot of these things. The chief technology officer, chief information officer back then was trying to get email up and running. You know, they certainly weren't focused on being a fully HIMSS compliant digital level 7 hospital with no paper. So times have changed, things are really right for this technology. So at Schneider, we focus on it and really look at it as connected products. You know, we actually make over 1 million different SKUs and manufacture products that are IoT ready. We then look at the edge level and how do you control? How do the people use the software at the facility to really run the hospital? And then you look at that top layer with apps and analytics. And what analytics? We've talked a lot about analytics, but there's also a huge opportunity in the startup world for developing apps, working with companies like Schneider, developing apps that run on mobile devices. You know, on this project, we're looking at BYOD, bring your own device, allowing you to download an application to the patient's phone or to the family's phone to control the footwall that you see behind me. You know, if you can work through the cybersecurity issues, that's a great opportunity to really do startups and do that type of development. And once again, end-to-end cybersecurity, I can't underestimate or understate how important it is and how much our industry has changed. Being in this industry for over 30 years, I really understand how we've approached things, and things are changing. This is really driving a different point and a different outlook on how you design your networks and how you lay this technology out. All right, you heard me talk a lot about use cases. So use cases are basically a way that we've taken a Division 25 specification, which is really around integration under master spec. We've developed written paragraphs that really translate the business value. So you can sit on that design team and you can tell them, what is the value of doing this? It defines the actual functionality and makes it part of the construction documents. So when this goes out to a competitive bid process, the customer knows they're getting the best price, but they also know that this technology is going to be delivered and not get value engineered out. So one of my favorite use cases, when you start to look at segments, what you realize is many segments are the same. So if you look at hospitality, it actually has the word hospital embedded in it. Part of our underlying theme on this project that I've been working on for the last 4 years was really around making a hospital more like the hospitality industry. So if you look at what happens in a hotel, when you check in a hotel, that registration system sends a command to your thermostat to basically set your set point so it starts heating or cooling so you're comfortable by the time you get to your room. But when you're not in the room, it's been saving energy. And the opposite happens when you check out. When you check out, it changes the set point. So why not do the same concept in a hospital? I showed you earlier that 53% of the energy used in a hospital is around those air exchanges. So why not focus in on, there's a system just like a registration system called ADT, Emission Discharge and Transfer. Actually, if you're a fully HIMSS compliant hospital, you're tracking the schedule of the patient throughout the day electronically. So those messages are all sent via an open protocol known as HL7, or the next generation is called FHIR. Why can you not connect to the middleware of the healthcare system, prove that you're HIPAA compliant, and now have your building management system actually track occupancy of a patient and now do an energy setback in a patient room, impact that 53%. So we developed the software about 5 years ago, and there was some kickback because they were worried about the Joint Commission, and they were worried that they wouldn't approve dropping the 7 air exchanges back. Well, I'm happy to tell you 4 years ago, we submitted a change to ASHRAE 170. I have a gentleman who works for me that sits on one of the boards, and that was approved a few months ago. So there's a new change to ASHRAE 170. There's now a spreadsheet included, which each type of room in a hospital where you can do this type of energy setback. So this is the opportunity to really save hundreds of thousands of dollars for a healthcare system each year based on what the mechanical design is. So it brings together technology with typical mechanical type systems that have been brought in. So this is what a use case looks like. It's key that people can sit down. We've developed about 110 to 115 use cases now, crossing over the 28 different low voltage systems. No hospital does all of them. The other thing that I would say is a lot of hospitals we've learned you don't have to turn on all technology day one. So a key point here is build the infrastructure into the building so it's there. And then over time, turn on technology. So the staff is not overwhelmed day one. They have to learn how to do their important job of taking care of the patient, where they get their supplies, where they get equipment. Let them do that. Let them settle in and then turn technology on over time. So that's one of our missions. Build the infrastructure, turn it on over time. So there's a set of drawings included. So if you go to that website that I mentioned where you can download all of the technology and there's a lot of specifications for the consultants, this set of drawings is on there. And I'm not going to have time to run through them in detail, but we developed these 20 pages of drawings with the use cases to really allow people to visualize what this looks like. It's laid out as the BMS system, the security riser, the power infrastructure, the emergency power monitoring. It's about that edge level with the software. And then let's not forget, for every major hospital, there's probably 25 to 30 or 40 office buildings or clinics that are feeding that hub and spoke model. So if you look quickly, I'll just show you a couple examples. This is really what the BMS, your building management system, can really do for you. With open protocols and that processor power, if you have a device like you see on the left that's talking 8 open protocols, why are you putting an individual network controller in for all these different systems? So it's really looking at breaking down those silos, making efficiencies that allow you to use one PLC controller for, let's say, lighting control, noise monitoring, building management system, integrating into your UPS and the TDR room to pull alarms out of that data, tying into your isolated power panel that's in your operating theater. All of these things become possible now, and what's great about it is it actually reduces the cost of your overall project. So many people refuse to look at or think about a smart hospital because they think it costs more. And in the past, it may have, because you came in and you did all these interfaces that I talked about. There was a lot of engineering cost. You did overlay systems, very complicated. Today, with web services and with the power of these devices, you can now pull out and really build these smart hospitals for less than what you're paying today. And it's really one of the key focuses. So here's a good example. In a specification for your building management system, there's usually one line item that gets written in there. And it's under the mechanical side, and it basically says, upon power failure, I want you to start critical equipment once the generators have come on and you've transferred over. What does that mean? That means you're monitoring the generators, the fuel tanks, you have your meter data so you know that you can transfer and start a chiller without doing damage. All of this is tied into your building management system. Well, in a second, I'll show you what your electrical system looks like. And by the way, that electrical system was procured and bought probably 18 months before you even started looking at the building management system on a project like this. So one of the things is these points, these data points that are needed for your generator testing on the electrical system, Same points needed by your building management system. Today, you're paying two different vendors working in a silo to put both those systems in. If I can share the data via web services with a common platform, I just eliminated that cost. And in this one example, it can be as much as $250,000 to $300,000. So if you download these drawings, you'll see here's your plumbing systems. Here's all the use cases related to your building management that I talked about as documented in Division 25. So you can see there's a lot of them. Here's your security riser. So this is really about, how do you do things like using your card access to control what is put into a pneumatic tube system and what can be taken out, and who can take it out at the other end. So if you're putting an oxycodone or a pain med in, narcotic, it requires a registered nurse. Integrated with the elevators. One use case that we're looking at and working on is for code blue. If a code blue team, if a doctor is wearing a tag that shows where they're located using the 802 Wi-Fi network to show where they're located, why can't I basically isolate where that doctor is? He's on the code blue team. I see that he accepts a call through his phone. Why can't I send a command to the dispatch elevator to have that elevator waiting for them when they walk the 75 yards? So if I can get a doctor to a code blue patient 25 seconds earlier, you could potentially save lives. So when I talk about needs, you can tell I'm very passionate about it, because it really has some pretty unique impact if you can help people in taking care of patients. Here's the security risers. Here's what it looks like from the electrical infrastructure. Your dual feeds coming in, your generator. We talked about distributed energy and how you tie that in. This next slide talks about the meters. So this is really, there's 5 reasons why you put a meter into a building. And I will tell you on a typical project, each one of those 5 reasons is designed by a different company or a different person within the same organization. And what that ends up being is we get to sell you a lot of meters that are measuring the exact same loads. I've actually seen projects where I've had 3, 4, as many as 5 meters put on a same load in a building. So they were put in because of power quality, which was done on the electrical side. So it was done very early in the process. Lead points typically under the mechanical. So it's part of the BMS, tenant sub-billing, sustainability, and then your generator reporting, which may be done up front, or you may actually wait and do it after the fact. So all key information in really bringing this together. Here's the use cases around power. Here's that edge level that I talked about. So that single pane of glass where you're now sharing data via web services. It's secured, it's running in virtual environments. You have secured connectivity to the cloud for the opportunity for the analytics. And it's really a great concept. So these are the set of drawings that are on that website. They're available. This is kind of showing you what is available for a lower cost wireless building management system to put into your outpatient facilities. There's a lot of documentation and white papers out there where these buildings aren't getting set back at night. Lights aren't getting turned off. You're spending a lot of dollars to put in refrigeration monitoring for drugs or pharmacy areas as well as lab areas. And a lot of times you can really focus in. So several of the studies we've done, you're getting as much as 30 to 35% savings on energy with a payback in 18 to 24 months. So it's hard to come by that, but these are great opportunities for these remote buildings and clinics. All right, I'm going to wrap up here, just a couple more slides, but what I really want to talk about and emphasize, I will say for everyone out there, 8 years ago when we built this technology and we started going out and selling this, what I didn't realize is we may have the best technology in the world, but it doesn't mean you can sell it. And what I mean by that is figuring out how to work within the general contractors and the design firms to understand, and the end customer to understand how to contract technology. That was the challenge. And I'll be straight up and tell you that we lost a lot of our first jobs until we really learned how to talk about how to contract and how to bring together really all of the different low voltage systems to do it at the same kind of price. So just a couple slides. If you start to think about contracting, what you realize is because these RFPs go out, some are direct to owner, some are to the general contractor, some may be under mechanical or electrical subcontractors. What you end up with is all these disparate companies coming on the site, bringing their own project management expertise, subbing out to electrical contractors that do the low voltage wiring. There's a lot of opportunity to gain efficiencies. So if you look at kind of the approach we've taken, it's really about bringing them all together under people that understand technology, build labs like you're seeing behind me, have project managers that understand how to execute technology, and look at those 28 systems and figure out what systems are right for this project. And I say that meaning that there's a lot of projects where you may have a card access system that's used by a university in the whole campus. You're not going to change for one building. But there is opportunities to make change and look at, there's a lot of reasons now to look at new systems and not just live with the incumbent that's not bringing anything new. So bringing in the team that can really execute this efficiently and really deliver on solid technology is extremely important. And if at the same time you can reduce stacking of trades, because now I'm putting one contractor in doing multiple systems instead of 3 or 4. So what did I do? I reduced stacking of trades. I reduce injury because there's less people on the job, so I have less accidents. It speeds up the schedule. So it's a win-win for everyone across the board. And if I can say anything, understanding those needs and how you take whatever your company, whatever your product is that you're developing and sell into those pain points and needs, it's really critical. So what we did was we approached it. If you look at those 5 core systems that I talked about, building management, power quality, security, the different systems, your emergency power testing, if you focus in on those 5 core systems, and you can actually buy this single pane of glass, what ends up happening is you eliminate, there's a lot less hardware, a lot less installation, structured cabling, project management efficiencies, contractual efficiencies, and a lot of site efficiencies. So you can save as much as 12 to 15% if you can go with 4 or 5 of these integrated systems under those 28 packages. It allows you to reduce and really save on the cost. So to kind of finish up, we're really trying to figure out how to do a better contracting. So I talked about it. You can build the best technology, you can invest millions, but if you can't figure out how to sell it and get the PO, I had an old boss that always taught me this, then what good is the technology? So what we're suggesting, bring us in as a technology expert, or bring in a technology expert, but I kind of prejudiced to Schneider since it's my team and I think we're good at this, but bring in an integration partner to have these conversations. Look at developing the Division 25 specification. Look at procuring the power package, but let's have discussions about meters and all of the different technologies and IoT that we can put into a smart building. Let's start having that conversation 2 years earlier than we're having today. So you get those RFPs that come out. The power package for low and medium voltage is going to go out the way it always has. It's going to go through electrical contractors. But let's get the technology designed in, because there's substantial savings that can be provided by putting those meters, the right meters in the right place, and having them factory mounted versus installed after the fact. Look at your fire package. Make sure you get a BACnet card integrated so we can talk to whatever that fire vendor is that you prefer. And then the other systems, sit down and we need to have a conversation about, do you have a preferred BMS? Do you have a preferred security? Do you have a nurse call? What is the lighting control system? Start to look at all these different systems and see how they could be put together efficiently. So a couple quick examples before we run out of time. If you look at lighting control, Many of the vendors out there have a lighting control, and then there's a separate vendor for shade control. Well, they're all digital controlled at this point. So doesn't it make sense to have one vendor who has integrated shade and lighting control that's actually done at the room level? On one project I worked on, we saved over $1 million by really understanding the total install cost of lighting and shade control versus looking at it as two separate systems. So those are all the kinds of things that we try to do. Buy technology. Not only do you want to buy smart, but you also want to make sure that they're not conflicting with each other. You know, some examples we had is by putting an RTLS, real-time location system, with these exciters that use ultrasound to wake up a tag so you know the nurse has entered the room. What if that interferes with the occupancy sensor for the lighting control system? Or what if you choose an infrared technology, but you put infrared lights in to make your camera work at night for remote monitoring? What is happening here, and I have numerous examples of where technology conflicted, and if you put them in silos, didn't test them in a lab, it would have been very costly when the hospital went to open and things weren't working. So look at it as a complete package. You also want to evaluate how you contract it, how you implement it, and then finally, you really want to look at your maintenance agreement, because there's a lot of economies of scale. If you have one company trained on multiple systems, it's a lot more cost effective to have them on site to really do that support. And in saying that, I think I have 2 minutes for questions. Are there still people out there? Did I lose everyone and there's no questions? Not sure if I'm supposed to.
There are a couple of questions. I think that Jana jumped in and answered a few of them by message. But John asks, you mentioned a hospital where there are 24 Cat-CA cables per patient room. Do you see any of this going wireless? It may be a bit congested with all the drop cords from outlet ports to the devices. Thank you.
So I see wireless being used for sure, but the channel is one of the big problems right now is the lack of, and I probably won't say this correct, I'm not a total IT person when it comes to wireless, but the channels and the frequencies that are required. Most of the hospitals, if you read, Cisco has a great white paper that they put out about how to lay out like the 7 different channels that are laid out in the different Wi-Fi networks. So you have, very critical, like your telemetry devices that move with you when you're on a patient, is being rolled on a bed. Those are very critical, so they have to be reliable. And it goes from the most reliable Wi-Fi network down to the patient network, which they now have for the patient to get on and, surf the internet. So one of the big problems that we've seen is they're concerned about channels and frequencies and just not enough available at this point in time. Not to say that that's not changing with other frequencies being released. A prime example, the monitor behind me, it's a 75-inch monitor. They very much wanted to have the ability to mirrorcast. Well, if you understand what Microsoft mirrorcasting does, it actually uses the Wi-Fi to do that, and it can take a lot of the utilization. So we weren't allowed to do that. So I do see stuff going Wi-Fi. The problem is the concern over too much and not the lack of, and I'm not sure I'm using the right word, frequency or channels to support everything that's going Wi-Fi.
And we had a question earlier from Kevin. What emerging infrastructure technological advancements are you most excited about?
I think bringing them together. I think the concept of room controllers and IoT sensors, I think the concept of sensors that now have multiple purposes. I think wayfinding, if you look at, for instance, the lighting industry, they're all putting Bluetooth sensors in. So I think the ability to walk around a building and know where people are and really bring that data together, I think is very exciting. I also think that being able to capture that data and now pushing it in the cloud securely, I think what we're going to see over the next 10 or 15 years is really the analytics. We call them advisors, but the ability for the data to tell you what's wrong with your building, I think is going to be brilliant. And I have a pet project. So if anybody out there can figure out how to do this, I swear I'm going to get this accomplished before I retire. You know, ASHRAE is published, if you look at a lot of other countries, the windows are open in hospital rooms and patient rooms. And ASHRAE has written the standards. I talked about us getting them changed, about 7 air exchanges, you know, reducing infection control, and it's all very important. But I would love to see the data behind that. So if you think about temperature and humidity in a patient room, tying that together with weather data from the outside, tying that together with hospital acquired events that are tagged in the electronic medical records, and being able to go back 7 or 10 years with analytics and see if there truly is a trend between increased infections and temperature and humidity and control within a space. You know, I think it would just be fascinating. I would love to see that done. And as of today, the data's there, but it's all in separate places. And, you know, people haven't pulled it together yet. And I think you're going to see that happen over the next 5 to 10 years. And I think it's going to be real interesting to see that evidence-based data really start to guide the industry.
Okay, I know we're at time, but if you still have some time, there's a couple of questions left.
Okay.
Luke asks, can you just speak to robustness? While getting an elevator primed for a doctor to save 25 seconds on code blue call sounds good. What happens when a port gets blocked and the doctor is sitting on an elevator that's never coming?
So number one, I agree with him 100%, and it has to be proven out and it has to be evidence-based. So what we're doing is laying the infrastructure to be able to do it. And to me, the missing piece that we didn't have until recently was the fact that that doctor will now have a mobile phone where they're responding and saying they're accepting the call. And if that doctor doesn't get the message coming to his phone telling him what cab is waiting for him, he's going to go ahead and take the steps, or he's going to call the elevator the old process. So anything we do with technology, we're not eliminating old school. So as an example, turning the lights on and off in a smart patient room. The switches are still on the wall. The pillow speaker still works the way it's always worked through relays, or hopefully one day we'll have a digital pillow speaker that can be done at an IP level. You still have an app on a tablet at the bedside. So even though we add technology, we never eliminate it. And the main reason for that is not all patients are at the same acuity level to be able to really manage that technology.
Okay. And Lewis asks, applying the IT for healthcare infrastructure's guidelines is sufficient/updated to have all requirements that you have spoken in this presentation, or there is a need for an update on those guidelines?
So I would say a lot of the FGI guidelines and ASHRAE are improving. I actually have someone I work with on the project here that sits, Kathy Gallagher actually sits on the FGI guidelines board, and she's a clinical and a nurse. So I think we are making progress in that sense. Where I will tell you that I don't want to say failed, but where we learned a good lesson. As a manufacturer, I talked about the analytics that we created around the power equipment. So that analytics, we can actually look at, for instance, one of our breakers that we make, and now we could schedule maintenance based on actual real life data usage. Because when a breaker trips, it's supposed to be able to trip like 100,000 times, but if it trips and there's a fault, different phases, different voltages, it can do a lot of damage. And our breaker's smart enough to see that now. So one of the things we learned, we were selling our what we call asset advisor, where it's looking at power equipment and telling you're at risk. And one of the value props we were selling was the fact that you could save money by doing maintenance based on actual data. Well, guess what? The Joint Commission says that a healthcare system has to follow the manufacturer's recommended maintenance schedule. Well, our maintenance schedule was based on time. So what we realized we have to do as a manufacturer, if analytics is truly going to work, we have to go back and adjust our manufacturer recommended maintenance schedule to be tied to both time schedule as well as actual analytical data. So I think the biggest change now is almost as a manufacturer and understanding the value. It's just like us to create reports that we sell for, let's say, generator testing, but they have to be then modified for the Joint Commission. So I think it's everyone working together, taking the data and making reports and information correct the first time around.
Okay. And our last question is, this makes sense for new construction. How do you sell it for renovation work where a range technology exists, where a range of technology exists?
Yep, so you take one use case at a time, and you start small with the budgets they have. So if you go back in time when the Affordable Care Act was passed, what was happening? They were going floor by floor and remodeling patient rooms because of patient satisfaction, and they were taking dual occupancy patient rooms to single occupancy. So that was an opportunity to come in and implement some of this. Through open protocols, a lot of our integrations can be put in with systems that aren't a Schneider product or aren't, necessarily manufactured by us. So that's one option. Another example is NFPA 99, when they considered an operating theater a wet area. That gave us the opportunity to really go in and look at isolated power panels and how can you integrate to them. So I am a firm believer, and honestly, my whole career has built upon change in regulatory kind of code and being smart enough to understand that that's leading to an opportunity. It started many years ago in the phone company. Very few people know that, Verizon, AT&T, and Sprint, the hard lines that used, the copper lines that went to your house, very few people realize that every 4 miles you have a central office, and that central office had an in-ground fuel tank with generators. So they were the largest owners of in-ground fuel tanks in the country. And when the EPA passed a law that said you had to monitor all of those fuel tanks, it wasn't the gas stations you should have been talking to, it was the phone companies. And that's just one example over many over the years where change in technology really gives you the opportunity to implement this type of technology and get a footprint in and then grow from that base footprint that you put in. Service, service, service.
Thanks. And that was the last question. I will ask if you don't mind sharing your contact information. I think you'll probably get a flood of LinkedIn requests today. But if people want to get in touch, I think you're in our community, so we'll make sure that you're in our Slack community in case people want to get in touch that way. This was recorded, so if you have to drop off or you want to reference it, we'll be in touch with how to get access to the recording.
Yep, I'm simply, if we go back to that first page, I'm Warren.Rosebraugh. It's ROSEBRAUGH at SE.com. Quite
Perfect.
simple.
And I see Jana has posted that in the chat, so feel free to grab that. And thank you so much, Warren. I think this was a really great presentation.
I'm glad everyone stayed around. Hopefully I could make it a little different for people who are on the call and keep people interested. So thank you for the opportunity.
All right. Have a great afternoon, everyone.